Maria Clemestrud with Comagine Health, and I'm just really happy to be here today and get us started. Next slide. So you'll see view options at the top of your Zoom. You can click on that and choose a stamp. Go to annotate and then choose a stamp and put your mark on the map. Tell us where you are. We would love to know. Lots of representation from lots of states. Yay, Oregon, Ohio, Nebraska, Iowa, Minnesota. Thanks so much for joining us today, spending your time with us. Louisiana, Florida. Love it. And you can continue to chat in where you're from and who you are. We're just glad you're with us. Next slide, please. Today, we are grateful to have 3 exceptional panelists talking with us about cancer survivorship, opioid use and abuse. And this project is funded through the Washington State Department of Health and through OD2A funds. And next slide. We meet every month, and we are excited next month to be talking to 4 nurses. It's our first 4-panel event and talking about the role of nurses in caring for patients with OUD. And in August, we are going to be learning about characteristics of successful learning collaboratives from those in the field that have new information about learning collaboratives, and then just different ways that they have learned to bring in diversity into learning collaboratives as well. So please join us in July and August. And we will be here in September and October, and we'll be announcing that next month, we hope. Have some great topics coming your way. So this is not the end. More to come. Next slide. So we will quickly do introductions, and so we can get straight to the content and hear from our panelists. We'll break into groups, breakout groups. We'd love for you all to stay for that. It's a great way to get a deeper dive into the material, ask questions. The panelists go into the breakout groups with facilitators, and then we come back for a lightning round report out. And those resources and the information that's shared there will be on your key learnings that you'll get next week. So please stay with us for as long as you can today. We really want to hear from you. We learn, I would say, the most from the peers in the breakout groups. So we would love to have you stay with us. Next slide. Thanks to our Comagine team that facilitates our breakout groups, and for those that are behind the scenes with technical support. We couldn't do it without all of the participation and the help from our Comagine colleagues. So thank you so much for that. Now I want to hand it over to Dr. Michael Parchman, who is the facilitator for this event, and we'll introduce our panelists to get us going.
Great, thanks, Maria. Really appreciate the introductions. So today's topic is cancer survivorship. Why are we talking about cancer survivorship? This topic actually came up in a needs assessment that we distributed to many of you back last year when we were developing topics for this webinar series. And someone, or more than one person actually, brought up this issue of cancer survivorship and its intersection with the opioid crisis and with opioid use. And so we thought it'd be very helpful to talk about that topic today. Before we begin this conversation and before we introduce our panelists, I just want to say a word about stigmatizing language. I think I used a phrase in our last peer-to-peer session that may have reflected a stigmatizing language. I used the phrase opioid use, misuse, and abuse. And someone rightly pointed out that opioid abuse may be perceived by some as a form of stigma. And so I just want to reflect on the fact that this is a journey, I think, for all of us, including me, in terms of language we use and making sure that the language we're using is respectful and is supportive of people who are in the process of recovery, or who are trying to launch their journey into recovery. So just as an opening comment, I just wanted to talk about that for just a minute. So thank you for letting me bring that subject up here today. Let's turn to the panelists, and let me introduce our panel members today for this conversation about cancer survivorship and opioid use. Can you put the slide back up again, Teresa, that has the panel members on them? Great. So we're really pleased today to have three people join us. Tanya Edwards is a family nurse practitioner in the Department of Palliative Care at the MD Anderson Cancer Center in Houston at the University of Texas, Houston. And her colleague, Dr. Joseph Arthur, who's also in the same Department of Palliative Care at MD Anderson. And Pam Stitzline, Pam, am I saying that right? Is it Stitzline?
Yeah, Stitzline.
Stitzline, thank you. Stitzline Davies. Pam and I got to know each other through our work here in Washington State on a different project about opioids in older adults. But she's a family nurse practitioner as well, or nurse practitioner. I don't know if you're a family nurse practitioner, in the School of Health Sciences at Salem Pacific University. So let's just launch our discussion. And I'm going to start with you, Pam, and just ask you, can you tell us a little bit about your clinical experiences when it comes to managing patients and managing pain in patients with a history of cancer?
Well, thanks, Michael, and hello to everyone. I'm glad you're here, and I really appreciate this very important topic. I'm now retired, but I have spent more than 10 years working at Seattle Cancer Care Alliance. I actually started up the supportive and palliative care program way back when that was number one, a new thing, and number two, fairly non-existent in the outpatient setting. So we started that up because it was a new program. I hired on for the cancer pain clinic at SCCA, as well as starting the supportive and palliative care program. And I did find, especially in the cancer pain clinic, that we had a lot of patients that were not just active cancer, but a lot of patients who were done with their treatment, but still had a lot of pain, as cancer survivors do. And a lot of opioids were being prescribed to treat that pain. And so we really had quite a focus on cancer survivorship and pain management in that setting. I also have a background in pain research, several different grants in neuropathic pain and that kind of thing. And then when I was a new nurse practitioner, I was at the VA doing primary care at the VA and also managing pain in the neurology clinic. And then before that, I was a floor nurse, an ICU staff nurse, charge nurse for 15 years, I think, before I became a nurse practitioner. So kind of been there, done that for a lot of things.
Wow. So that's great, Pam. So many of our participants don't have a clinical background. Can you describe for us just briefly the array of pain syndromes that we see in cancer survivors? How would you describe that? I think it's important to set the context. And if we're talking about pain management and opioids used for pain in patients who are cancer, let's talk about this context of what types of pain do cancer survivors experience?
Yeah, thank you. That's real important. And I'd first like to just reaffirm what I had discussed separately with Michael, that for this talk, we're discussing cancer survivors as somebody who's completed their active anti-neoplastic phase of treatment, with the exception of hormonal therapy for conditions such as breast cancer, aromatase inhibitors, or tamoxifen for prevention of cancer. They have no current evidence of disease. They're under cancer surveillance. And the cancer pain syndrome is not related to active disease. So that's, I think that's important, because if you look at American Cancer Society website, they'll refer to a cancer survivor as anybody with cancer. So we're kind of looking at this niche here, but there's a lot of pain that happens in cancer survivors. Some conditions like post-mastectomy or post-thoracotomy pains, syndromes. I mean, 80% of patients with who've had cancer in the lung or the breast, up to 80% can have chronic pain on just across the board. At the average breast cancer survivors, 63% can have pain, and many conditions have chronic pain after cancer. And the pain can occur, 3 to 5 years, 10 years, 20 years. I mean, it can be a really long lasting chronic pain syndrome. And interestingly, the pain is primarily from the treatment for cancer. So surgery, like a post-mastectomy, post-thoracotomy syndrome, it could be from the chemotherapy. You can get chemotherapy-induced peripheral neuropathy, painful or non-painful, radiation plexopathy. So again, breast cancer, a lot of, or some kind of lung cancer. You can get pain in the chest wall, movement of the arm. You can get shoulder impingement syndromes, all sorts of things like that. And so the chemotherapy, the radiation, and the surgery, all of those can cause it. And neuropathic pain is very common in cancer survivors. And as you know, neuropathic pain is just a harder thing to treat. It's just generally harder. And in addition, neuropathic pain is less responsive to opioids. And so that's important to look at.
That's great. Thanks for that overview. So can you talk with us a little bit about managing opioids in cancer survivors? What was your experience and what have been your observations?
So I want to go way back to point A, and point A for me is to remember that any cancer survivor, and I'll just say out front to the group that I'm a cancer survivor. I've had cancer of the breast, and I have chronic pain related to that. And let me just say, I know this deep in my heart, that any pain in a cancer survivor is worrisome for recurrence of the cancer. So I think first and foremost, providers and clinicians and those working with cancer survivors have to have that in the forefront of their mind. They can't just blow it off, oh, chronic pain because of radiation therapy or something. That cancer survivor is thinking, oh my gosh, I'm worried that the cancer has come back. So whenever we're treating chronic pain in anybody, but especially in the cancer survivor, we have to look at the fears that are deep down inside there. We also need to remember that clinicians need to be alert to changes in whatever the pain syndrome or symptom is, because maybe it is a recurrence of disease. So if somebody does have low back pain that starts up, the guidelines are for, just the average patient, you wait 6 weeks, you try, standard therapies, physical therapy, stretching, things like that. With a cancer survivor, you may not do that watchful waiting. Yeah, depending on the case and the individual risks, you might go to imaging a lot sooner in the cancer survivor. So that's point number 2. And then I think it's really important that we do really good patient education because in my experience, many patients who have had cancer are used to, when they have active cancer, they're used to saying, I have pain, they get a prescription for an opioid. They say, I have more pain, they get an increased prescription for an opioid. Or they say, my pain flared with this thing, I doubled my dose, and the team says, okay, fine, we'll give you that double dose of opioid. So there's a lot of education that, to us, we may know what's appropriate or not appropriate, but the patient's thinking, opioids are what we use for cancer pain. This causes cancer pain, and therefore I can take opioids and I can increase the dose of opioids. So I think it's just real important that we do careful patient education. Um, and the education, first of all, what I always do is I do a lot of reassurance and congratulations that, you know, the scans show that they're cancer free. So yay, you know. Um, and then we talk about education of what's causing the pain. It's the residual effects of the nerve damage, let's say from radiation or from surgery. Or for a lot of patients, like with radiation, they can have these shoulder impingements. They can get a lot of shoulder pain from various chest radiation. And so just education that this actually is like stiff muscles and fascia, that it's not the cancer. There's no sign that the cancer's there. And we also need to do education of providers, because I've seen that a lot of oncology teams, they'll just really give a lot of opioids to patients. And then when it gets a little out of control, they kind of refer them off to the cancer pain or the palliative care clinic to kind of fix it. And so going upstream a lot, I do a lot of education with the providers that that's not where we want to be with that.
Sure.
So the key thing is that the pain syndromes in cancer survivorship are usually managed with non-opioid therapies, usually. Focus on neuropathic pain strategies, so antidepressants, anticonvulsants, a lot of physical modalities, stretching, lymphedema management, things like that.
That's great. But some patients do end up on opioids long-term for their chronic pain. When did you become, or how, for a given patient, when do you become concerned about their opioid use? When does that start? You start going, there may be a situation here. What were the things you looked for?
So in cancer survivorship pain management, I look at it as a chronic pain model with the caveats that I just gave, that we don't do watchful waiting and we look for current reoccurrence. So whenever you have somebody that the goal with opioids is going to be to keep the opioid dose as low as possible within the guidelines that we have with the CDC, that were the 2016 guidelines or the current ones, and whatever your state is. But whenever somebody starts escalating their dose, needing more, running out of prescriptions early, when there seems to be a significant focus on opioids without doing the other strategies like physical therapy, unwillingness to take some of the neuromodulator drugs such as duloxetine or gabapentin. I always check the prescription monitoring program. I've done that ever since it came out, and kind of just check to see who's prescribing the opioids, and just a good conversation with the patient to see what their perspective is.
That's great. So Tanya, I saw you laughing at one point, or at least smiling a lot with some of Pam's responses. Did you have anything you wanted to comment on or follow up?
I love hearing all her responses because, of course, we've had those situations as well. So for us, people have lives before cancer. And sometimes they may have addiction issues or non-opioid medical issues before. They're human. So they may come into our supportive care, palliative care team for pain management. And then we have that to deal with. Plus they have this cancer and it's both probably stressful. So we're not here to judge, but at times we do have to have that conversation with them so we can kind of see what's going on with the patient. But, educating the team and the patient is a huge part of it and keeping them on the right track so they can focus on fighting their cancer. Absolutely.
That's great. And I'll just turn, Dr. Arthur, do you have anything you want to add? You're on mute.
Yeah, thank you very much, Dr. Parchman and the team for inviting us to join this panel. Yeah, so I completely agree with Ms. Pamela Davis and then Tanya in all the responses that they've given. So we work at MD Anderson, right? So MD Anderson is one of the huge, I mean, the largest, cancer hospitals in the nation. And so we see a lot of patients who come to MD Anderson for treatment, those who are in Texas, those who are out of state, and we see a lot of international patients. And so when they come, so we work in that department, palliative rehabilitation and integrative medicine, where I am an associate professor. And so what we do here is that we manage symptoms, patients' symptoms. So when they come to the hospital, and they are getting treatment. And here I'm talking about the other definition of cancer survivorship. Anyone who has cancer at various stages, early stage, active cancer, even at the end when they are not candidates for treatment. So they call us, we go see them, we manage their symptoms. One of the most distressing symptoms is pain, as we all know. And opioids, unfortunately or fortunately, opioids are the mainstay for cancer pain management. So we cannot, avoid it. So we have a lot of patients on opioids. About, I will say like 87% of our patients who are discharged from the hospital receive opioids. In the clinic, we have about 70 to 80% of our patients who are on opioids, right? Now, the problem is we have a subgroup of patients who have pain, who have true nociceptive pain, who are receiving opioids for pain, but unfortunately are engaging in what we call the non-medical opioid use behaviors. And so that is a huge issue that we have been dealing with. How do you manage these patients' pain? But at the same time, how do you keep them safe? So I completely agree with all the answers that have been given. So that's our research area of interest, Tanya and myself, that we're looking into.
That's great. So Tanya, can you and Dr. Arthur talk a little bit more? You've implemented a core team approach regarding opioid safety. What prompted you to do this, and can you describe that approach?
Absolutely. Well, of course, we wanted to keep our patients safe. So we did come up with the Compassionate High Alert Team chat. And it was, for us to come up with a specialized treatment plan for that patient. We were seeing a lot of non-opioid medical use. And like you said, the term before of saying like addiction, which is not always a friendly word to use. And because it could be from different issues why that person has that, or chemically coping with their pain medicine, maybe for anxiety or sleep, instead of using it, what it is really intended for is to manage that pain. So with our Compassionate High Alert team, the chat team, that team is composed of a clinician, whether it's a physician or a nurse practitioner. We also have a pharmacist, a palliative trained pharmacist on board, a psychologist, counselor. We have social work if need be, case management, and a patient advocate who we'd like to say that's Switzerland. They're there for the patient because we don't want them to feel like our team is ganging up on them. And then of course, security, if we have to add that person in as well, if the behavior is turning a little bit aggressive or defensive on just wanting that prescription, not wanting to answer questions, not completing the assessment or whatever the situation may be. It could be that they're going through withdrawal and they really need that. Maybe there's diversion, not quite sure. So within our chat team, we like to do a interprofessional team group meeting. We'll meet together before we talk to the patient. And then once we get to the patient, we'll say, hey, can our team come in and talk with you? And once they agree, and of course they're in the clinic to maybe be there for a regular pain assessment or constipation, nausea, whatever their symptom may be, we still address the need why they came. But then our specialized team will go in and talk with them about the behaviors that we've been noticing, or frequent calls for refills, or lost medication or diversion. So we'll have to address that. And then doing so after we talk with the patient and we have a personalized treatment plan for them based on that. This is all considered sensitive conversation going on with this. We have a specialized documentation that we use for this. And once all this is done and this comprehensive education that follows with opioid safety, for this patient and their caregiver, because caregivers are so important at this time too, to help them be supported during this time. and then longitudinal counseling if need be. This doesn't just start with this one team approach. We may have to come and see them back in a week or two. And then after we meet with the patient and we discuss all of this, these universal precautions and everything is set in place, then our team will have a post huddle. We'll discuss also, you know, how we thought this went, what could we do different for next time, or if we saw a lot of psychosocial issues really involving the caregiver or whoever, what needs to be done, making sure that caregiver knows how to use Narcan, whatever's in our opioid toolkit at that time that we can kind of help with that patient as well. So during that, we may have the patient come back in a week or two, depends on what happened. If this is like the second time the prescription was lost, or we filled it 2 days ago and now you're calling again for a full supply, we're not going to give a full supply. We're going to probably give a week supply and come back and see how you're doing, making sure you have that lockbox to keep your medication locked up and safe from theft, harm, or whatever the situation is. We're still doing this in a non-judgmental way. We're not going and blazing any guns at anybody. You know, it's all done out of love and concern. So that's why the C is there for compassion.
I love that description. Yeah. Dr. Arthur?
Yes, so just to add to what Tanya said, so this is a well-organized program that we have at our supportive care center. You know, so we have a chat team, we have a chat process, we have rules for each and every individual member of the team. We have a chat communication guide, you know, a framework that we follow. And it's been very, very helpful. You know, so what we did was, you know, as at MD Anderson, you got to publish what you do. So we always want to come up with data to convince our colleagues. So we looked at 30 consecutive patients that received the chat intervention. What we found, interestingly, was that the chat intervention resulted in a dramatic decrease in the number of non-medical opioid use behaviors from before the intervention to up to 3 months post-intervention, you know, and then even the MEDD, or the morphine equivalent daily dose, also dropped, you know, significantly. So that was very encouraging. But here's a case, we had a small sample size. So then what we did was that we had to do a second study with a bigger sample size and a longer time period, a follow-up period. So we recently completed a study which we submitted to one of the major journals, Cancer Journal. And so we have like 130 patients. And what we found also was very similar to what we found amongst the smaller cohort. And so the chat intervention was associated with a decrease in non-medical opioid use behavior from about 2 to 1. And then those who had complete response, and you know, if you combine those who had complete response is absolute resolution of all those behaviors. Partial is a decrease in number of behaviors. Stable is no change. And then worse is an increase in the number of behaviors. So if you combine the complete with partial, you're looking about 80% of patients who really did respond to the intervention. So that was very encouraging, you know, in our group.
Let me just encourage people to post questions in chat. If you want to ask a question anywhere along the line here, just post a question in chat for us about the discussion topic and the discussion we're having. So let me just ask Tanya and Dr. Arthur, would you consider this approach harm reduction, and if so, why?
Well, for harm reduction, absolutely. Because, you know, using the term addiction before and trying to reduce all of that, if they're still going through active treatment, then that may have to be the center focus. If we can't get, if it's cocaine abuse and our messages of our approach aren't working, which is a very small percentage of not working. But if there is like a cocaine heroin addiction that needs to be, you know, looked at more closely, then we'll refer them to the proper place that they need to go to help them with that. That way they can quickly get back to focusing on their treatment. Our goal is to get everybody through, you know, back to being functional with this pain medicine and let it do what it's supposed to do. But if they're not even really taking it, or we, you know, do frequent urine drug screens for our patients who are in, plus randoms for the other part of the population, because sometimes being quiet doesn't always mean something's not going on. So with that, and we'll involve the social worker to refer them to either Cocaine Anonymous or, Narcotics Anonymous or whatnot to kind of help get them back to fighting cancer. So that is very important for us. And that could probably be, I'd say the MOU section is probably about 20% and maybe about 5% or less of those who just need to go to rehab.
There may be people participants in the meeting who would like to learn more about chat and the approach you take. Is that described in some of the publications?
Absolutely, it is. And like Dr. Arthur said, it's our passion to work on this. We've seen so much success with this program, and we're there for them. And like I said, we're at a non-judgmental state where that they have bi-directional communication with us to let us know, okay, my pain is not controlled, and we're looking at their scans or what could be going on with their cancer, and we understand why they do need a little bit more. So between that and following each patient individual and not treating them as a group, which we will not do, we do see a lot of success in that, which makes us feel good. So this has become our passion for this. I work in the outpatient clinic for supportive care, palliative care. I also work on the inpatient side too. Two different worlds, especially when it comes to patients with this type of behavior. The outside is mainly lost, stolen, or frequent requests for refills. The inpatient is maybe IV dilaudid or morphine or whatnot excessively. So kind of a little bit different. And it doesn't seem like one side really crosses over to the other side. So I get to see both sides. Plus it also helps me track our patients if they're on the inpatient and now they're back to the outpatient. I can see who they are and where they are. We have a large team here at MD Anderson with our supportive care team from all the physicians. There's about 25 nurse practitioners. I forget how many physicians, maybe the 28 or so. Social workers, counselors, and whatnot. So all of us, the whole team has to function. One person can treat this patient and do a great job, but when your whole team is involved, that's when your miracle's going to happen. So with everybody on board, and I mean all hands need to be on deck, we do our best to keep our patients safe at all angles. Whether it's a triage, a walk-in for uncontrolled pain to our clinic, a scheduled appointment, sending a my message, whatever way they communicate, we'll accept it. And do our best to help treat them individually, like I said, or get them to the right person. Maybe this time to go back to the surgeon or whatnot. But we'll do that, and we keep an update. If we see that patient's on our schedule for the day, we will, everyone in the clinic that day takes note of what patient is in our opioid stewardship program, our compassionate high alert. And then we are all ready to work and help that patient out through the day in the clinic.
All right. Sorry, Dr. Parchman, just want to add a little bit to what Tanya said. I want to go back to the question that you asked about harm reduction, because I see a chat. Somebody posted in the chat. So in terms of public health definition, so yes, it is a harm reduction approach. It's kind of like a secondary prevention approach. Okay, so here's a case. We have patients who are at risk for NMOU that we follow. We don't utilize the intervention, but then when they engage in non-medical opioid use behavior, when they have the behavior but it's mild, that's when we implement this harm reduction approach and risk mitigation approach to prevent any further complications from those behaviors.
That's brilliant. That's brilliant. Any questions from the participants for our panel members? Pam, do you have any questions for Dr. Arthur or Tanya?
So it sounds like the chat program, which sounds absolutely fabulous. I would have loved to have had that back in 2006 when I started in this this area. But it sounds like it's for active cancer as well as the classic cancer survivor. Is that correct?
Yes, it is.
Yeah, and I just have found, from my experience, things were a little looser, I guess I would say, when there's active cancer. I mean, you still work on the opioid mitigation, safety, harm reduction. You're working on the opioid stewardship, as you're saying. That's a real tough one. It's a tough one to have an active heroin user who is coming in for a stem cell transplant and getting a Hickman put in. I mean, you know, we've been involved in those discussions, and that's really, really hard. So the program you have sounds fabulous.
Thank you. And one thing you mentioned about before, making sure other treating teams on our campus are aware of. So if we did have a patient, like you said, who needs to have those procedures and stuff while they're getting active treatment, we will alert their oncologists to let them know what we're doing. That way they can support us, we can support them, and they may say, hey, this painful procedure is coming up, and we're like, thank you, we're on top of it. That way we can, you know, like I said, we don't want to be judgmental. And I may be able to go in and see a patient completely by myself and do that, but I still talk to my team because I don't want to be biased in any way.
Right.
Yeah.
So that's why we have our pre-huddle and our post-huddle, because, you know, their life is very important and we want them to have their safety. We don't want any overdoses, but we want to also manage their pain.
And does the chat team prescribe the opioids, or does the primary oncology group prescribe the opioids?
We do, we prescribe. And actually we prefer only our team to prescribe.
Right. That makes it so much easier, because when people are
Mm.
prescribing willy-nilly and you're giving guidance and in the chart note nobody's following it, it really is tough. It really, one group should be the prescriber group.
Absolutely.
There's a
Well,
question
one thing
about.
we've, I'm sorry, go ahead.
No, please go ahead.
Now, I was going to say, just like Ms. Pamela Davis said, so managing patients with co-occurring cancer, pain, and then non-medical opioid use is probably one of the most challenging, you know, cases that you will ever deal with. I'm an addiction medicine specialist myself, and I always say, and that's my opinion, managing a patient who has a fully blown, you know, addiction, who has insight into the disease and who is willing to get help, is probably relatively less challenging as compared to managing a patient who used to have, you know, OUD or opioid use disorder, or not, something that's not very clear, a behavior that's not very clear. Then they get cancer, they come to the hospital, we give them opioids, which we know can create problems. So it's kind of very difficult to you know, manage such a patient, especially because they don't have an insight, or even if they do, they don't express most of the time, you know, that insight into their condition, that they are actually abusing the medication. And so you have to be able to help them come to that point. And one thing about opioid use in such a patient is that, unlike in addiction, abstinence is key, right? You want to prevent them from using the opioids on the street. Here, you need the opioids because they'd have true nociceptive pain. So you got to manage the patients with the opioids. At the same time, you want to keep them safe. So that's one of the challenges that we deal with when you have a patient, you know, with both conditions.
That's a great insight, and we really appreciate that, and we really appreciate all of you for our panel. Unfortunately, we need to switch gears and go into our small groups now for a little bit. So I'm going to pass the baton back to Teresa to get us in our small group breakouts. We've got some questions for you. Please stay and join us, and then we'll reconvene shortly before the end of our time.
All right, in about 1 second, you will see invitation to join a breakout room.
Right, and the questions for your discussion are in the chat, which you should be able to access when you get to your breakout room.
All right, people are coming back. They might trickle in. We had about 30 people hang on, so.
Why does it say 8?
I think we are still waiting for people to come back from their breakouts. It gives them about 60 seconds after the room is closed to accept it and come back in.
Gotcha. Okay. Welcome back, everyone. Welcome back, everyone. We're so glad that you stayed with us. I was in the best breakout group number 1. And I know we have 4 other breakout groups that probably are pretty good too. Does anybody feel comfortable sharing what they learned in their breakout group?
Well, I'll just say, this is Rebecca. In my breakout room, we was encouraging to hear that there are, drug monitoring programs that are integrating the PDMP into the EHRs, as that's something that will be quite useful for all as we move forward in this, and putting that information squarely in front of the prescribers to be able to access, that they notice that most often the queries were from others. And so to get that information directly in front of the prescribers will be great in that area. And somebody starting up a new peer navigator program, which we've heard from the panelists today are so incredibly useful and provide a lot of value to patients. So yeah, nice to hear about that and all the community outreach going on to get that up and going.
Other group report outs.
All right, for our group, how you doing? My name is Felix Pacheco. I'm from New Jersey. So we kind of discussed cancer-related individuals that are dealing with cancer and related to opiate use. And the one thing that I learned from this discussion was, in New Jersey, I don't believe we're asking that question when so we do a lot of different operations where it's law enforcement based operations where we provide law enforcement operations in conjunction with recovery support specialists and coaches and support services on individuals that they interact with on either arrest based or non-arrest. And the question for us was, how do I integrate that into our program to ask that question? Because I don't believe that we do ask that. A lot of times we're dealing with individuals that are active users for not only opiates but other heroin and cocaine and meth and other drugs. So that was something that we discussed, and I don't think we really got an answer of how to integrate that into a checklist question, because I know confidentiality is and HIPAA and is all involved. So that's something I'll bring back to my agency to say, hey, this is something that we discussed.
Thank you. Good to see you, Felix.
Same here.
Other input. I can share that my group talked about being reassured personally of when they have pain, and kind of a historical growing up issue of watching pain in the family, and pain meds in the family, and then now as an adult, having that history, which I think is so significant to who we are as adults. And I think, Pamela, to your point about the worry that a person would have when they do have pain, really resonated with the participant as a human being and as from their story. And then also, we were just really impressed with Tanya and Joseph's program to ask permission to come into the room, and just honoring the patient, and just that relationship that is a partnership that is there for safety and advocacy, because so often historically, because drug use is criminalized, there's the adversarial approach. So we were just really impressed with your program.
I'll share that we had the privilege of having Dr. Arthur join our group, and we had I think an interesting conversation about the role of buprenorphine and Suboxone in managing patients, cancer patients with pain, especially those with a history of substance use disorder. Talked about methadone as well, and its role in their program. And then Dr. Arthur shared with us the chat, the publications that are in the chat right now about their program. So you can click on the links in the chat. And there's a third publication that should be coming out any day now that has more details about the chat program. So keep an eye out for that publication as well. Maybe go back and check in a month or two, see if you can find it on PubMed.
Wonderful. Any other thoughts or comments from your breakout group? It's great to see. Oh, hello, Alicia.
Hello. Yeah, so I believe I was in breakout group number 2. We had some really good conversations surrounding the commonalities kind of between cancer survivorship and substance use disorder and those challenges that they may face. And so, you know, whether that may be housing or survivorship pain. We then talked about the potential associated suicide with the survivorship pain and misunderstanding and potentially self-medicating and overdosing. We then also kind of discussed a managed care program that I manage with regards to approving opioids and having pharmacists do a clinical review for their regimens. But the overall consensus was just to make sure that there's a coordinated effort across the board, excuse me, to make sure that patients are taken into account, their perspective, making sure their safety is taken into account, but also making sure their pain is treated.
That's wonderful.
Great comments.
Well, we are 2 minutes to the top of the hour, and we have 30 people staying. Thank you so much. Please don't go yet. We have a short poll. We use the poll information to make our presentation better, we hope. So there are you'll see 2 poll questions. Please just take a second to answer. And we're going to see the results before we leave. I want to just remind everyone that July is a very exciting topic around the role of nurses in treating patients with OUD. We will have a 4-nurse panel, and who doesn't love nurses? I was raised by a nurse. So we have we're going to have an amazing panel in July, and we'd love for you to come back and spread the word about our event next month. So hopefully, perhaps we can see the results of the poll. And wonderful. We have a great, wonderful. 100% heard something by attending, 91% plan to try something new. And we have one last question. Does anybody know of examples of use of the PDMP that also support linkages to care when high risk prescribing dispensing is identified?
I personally have not seen that at the University of Washington system that I've worked in. We were just lucky to get the PDMP start to get integrated into the chart notes.
I think most people feel just lucky when that finally happens.
And it's correct.
It is correct. Yeah. I mean, it's a great suggestion. I don't know of any examples. I think we're just not there yet. I think it's a great aspirational goal.
I think in West Virginia, ours has, if there has been a suspected non-fatal overdose, it's reported to the PDMP, and then the PDMP notifies their provider, and then they have an opportunity to reach out to the patient. That would be the only example I could think of.
It's a good example.
Thank you so much. And I know that the comment from Heidi is actually Amber. Hi, Amber, because she was in my small group. I agree with you. I think what you're saying is really important. Concerns about when a cancer patient is unable to take care of themselves and are being taken care of by a family member who may be an addict. So yes, very, very important comment. Thank you so much. We are 1 minute after. We're so glad you were with us and you stayed with us, and we hope to see you in July.
Bye, everybody.
Thank you.
Bye. Thank you.
Thanks, Pam. Thanks,
Thank you.
Tanya.
Bye-bye.
Thanks, Dr. Arthur.
Take care.
You're welcome. Bye-bye.
Thank you.
Bye.